be summarizing the cardiovascular risk management in diabetic patients. So you have gone through the guidelines and the new data, and just be revising those data and to see how you will implement these in real practice when treating a diabetic patient. So when you see a diabetic patient, the first in your clinic, the first thing comes to your mind are the blood sugar values that you can see and the symptoms that he comes along, which are due to the hyperglycemia. And as contrary to the previous practice, which was more focused with controlling the blood sugar values, as Dr. Osama Habib mentioned very elegantly, the paradigm has shifted in the treatment of diabetes. So it's a multifactorial approach, and to see the cardiovascular risk factors which are already in those patients or those patients who have high risk indicators of cardiovascular disease. So what we can do is to alter the modifiable risk factors, which are the smoking, sedentary lifestyle, obesity, and diabetes, which is the major cardiovascular risk factor. And mentioned here pre-diabetes, as very eloquently mentioned by Dr. Saghir before, that you can have microvascular complications, macrovascular complications in pre-diabetic patients. So this is the right time to intervene to manage these patients to reduce their cardiovascular risk for the future. And of course, hypertension, dyslipidemia, kidney disease, and albuminuria. Now, atherosclerotic cardiovascular disease is defined as coronary artery disease, cerebrovascular disease, or peripheral artery disease, which is presumed to be atherosclerotic in origin. And this is the leading cause of morbidity and mortality in diabetic patients. Two-thirds of deaths are attributable to cardiovascular disease in diabetic patients. These patients, when compared with general population, they have 2 to 6 times higher risk of mortality from cardiovascular events and 4 times greater risk of coronary artery and stroke. Now, atherosclerosis is a progressive disease and starts very early on, and there is a linear progression of cardiovascular disease with time. Unfortunately, in diabetic patients, this rate of atherosclerosis is accelerated, and this leads to increased risk of cardiovascular disease in these patients. And at the same time, there are other common conditions which coexist with type 2 diabetes, which are hypertension, dyslipidemia, and other risk factors that we mentioned, and they all are risk factors for atherosclerotic cardiovascular disease. Now, if diabetic patient has a cardiovascular disease, their life expectancy is expected to be reduced by 12 years. But of course, we have now modalities and interventions to reduce this atherosclerotic cardiovascular disease risk in diabetic patients. And the approach that I'm going to emphasize here is the multifactorial approach. So it's not only treating the glucose values or treating the HbA1c. It's basically to address all the cardiovascular risk factors in a diabetic patient. So this does not include only the glycemic control, but also lifestyle modification, lipid management, blood pressure medications, and in appropriate patients later in patient. Now, I quickly go through these very old studies. The Standard 2 trial, which looked at the multifactorial interventions in CVD in type 2 diabetic patients. So they looked at type 2 diabetic patients and compared, and they did multifactorial intervention in these patients. And the interventions were behavioral modification, pharmacological therapy to control the glucose, hypertension, dyslipidemia, microalbuminuria, and aspirin. They followed these patients for 8 years. These are the intensive therapy group, which received less than 30% of calories in their diet, of which less than 10% were the saturated fats, exercise, smoking cessation, and all the medications. And they found out that patients in the intensive treatment group, the greater proportion of those patients achieved the HbA1c, achieved a cholesterol value of less than 175 milligram, and achieved a systolic blood pressure of less than 130 millimeters of mercury. And this is the most benefit that came out of this study, that the intensive treatment group from primary composite endpoint of death from CT causes, non-fatal MI, CABG, PCI, non-fatal strokes, amputations, they were all significantly reduced in cases of intensive therapy as compared with the conventional therapy. So in summary, the intensive care treatment reduced the cardiovascular disease by 53%, nephropathy by 61%, retinopathy by 48%, and autonomic neuropathy by 63%. So when we talk about lifestyle modifications in our diabetic patients, there are many studies, especially for type 2 diabetes prevention studies. They have very positive outcomes in terms of preventing or delaying the type 2 diabetes. But what about the cardiovascular disease, is the prevention? Can we achieve that with lifestyle modification? So this has not been established very clearly. Now, in this one study from China, the Chinese diabetes study, they found that the cardiovascular disease was significantly decreased in former intervention group compared with former control group. And this difference started to be visible after 10 years from randomization. This was 4 years after the intervention program has been stopped and became statistically significant by the 23-year-old follow-up. What it essentially tells us that the cardiovascular benefit of lifestyle modification takes time. So it will translate into cardiovascular benefit after a long period of intervention. Similar, some studies from Sweden, they looked at patients with impaired glucose tolerance and they provided lifestyle intervention and compared the cardiovascular disease outcomes from men who did not take the interventions. And they found out that the participants who were in the intervention group, indeed, they had cardiovascular disease mortality lower as compared to the other group. Similar results from a Finnish study also showed there was more than 50% reduction in mortality, those patients taking the lifestyle intervention in patients with impaired glucose tolerance. So these studies basically tell us that if you intervene early, so we can reduce cardiovascular disease in these patients by lifestyle modification as well. Now, much has been talked about the glucose lowering medications and the effect of low glucose on cardiovascular disease. Clinical evidence suggests that improving glycemic control will reduce cardiovascular disease and mortality, and the benefits may be greater in individuals with shorter duration of diabetes and with no prior cardiovascular disease history. So, what about intensive control versus conventional control? Intensive glucose lowering versus conventional glucose lowering. So I'll just go through quickly through these slides. This is the UKPDS study, very famous study. We all know it, done on type 2 diabetes, which looked at intensive glucose control versus conventional control. And what they found was there was significant reduction in the microvascular complication, as already expressed by Dr. Osama. But no reduction in microvascular complication was seen, with exception from the metformin group that showed little benefit. So this was a small group who was taking metformin. The point I would like to highlight here is the UKPDS post-trial follow-up. These patients were followed up for additional 10 years after the completion of randomized phase of the trial, and those individuals who were originally assigned to the intensive treatment group, they continued to show vascular benefit, a phenomenon that has been called as the legacy effect. If I may remind ourselves that a similar phenomenon has previously described in type 1 diabetes, in the extended follow-up of the DCCT trial, in which it was labeled as the metabolic mandate. So another lesson from these UKPDS follow-up trial was the benefit of intensive glucose control may take many years to translate into cardiovascular benefit, unlike the lipid or blood pressure trials in which the benefits are typically seen within a few years. So this is the data from the UKPDS post-trial follow-up. We see 9% reduction in any diabetes-related endpoint, 25% reduction in microvascular, 15% in myocardial infarction, and 13% reduction in all-cause mortality. This was the 10-year post-follow-up data. Core trial has been mentioned by Dr. Osama that it actually showed that intensive treatment resulted in increased mortality, and this trial was stopped prematurely. Advanced trial also did not show the primary outcome was the advanced trial showed the primary outcome was lower intensively treated group compared to standard group. However, this difference was driven by reduction in microvascular events and not the incidence of major macrovascular events. So, conflicting data from these studies. So let's skip that. What trial, on the other hand, showed at the end of mean follow-up of 5 years, there was no difference in primary outcome between the two groups, so intensively treated and standard treatment group. So the meta-analysis of these 4 trials, this indicated that compared with less intensive glucose control, more intensive glucose lowering was associated with 9% reduced risk of major cardiovascular events, and this was attributable largely to the reduced risk of myocardial infarction. Mortality was not significantly reduced. If you see here, above major CV events and myocardial infarctions favored the more intensive treatment, but there was no effect on the cardiovascular death or all-cause mortality. So this has led to the recommendations we all know to lower the HbA1c of less than 7% in most patients. And in those patients who are at risk of hypoglycemia or have established cardiovascular disease, elderly patients who have chronic kidney disease, to loosen up the glycemic target. So in those patients, the HbA1c above 7 could be an acceptable target. And these patients, the aim would be to avoid hypoglycemia. Now, glucose lowering drugs for reducing cardiovascular disease have been talked in great detail by my colleagues. I'll not go into the details. I have an outcome study on pagliflozin showed miracle results, reduction in 3-point MACE, CV death, all-cause mortality, and reduction in hospitalization for heart failure. Leader trial done on liraglutide showed a similar benefit cardiovascular. This is an injectable GLP-1 receptor agonist. And the REWIND trial later on, done on dulaglutide, also showed similar results. But the importance of REWIND trial was that greater proportion of patients with diabetes with high cardiovascular risk were included without prior established cardiovascular disease. So about 70% of patients were high risk patients, but they did not have established cardiovascular disease. So importantly, this demonstrated basically primary prevention in these patients. So diabetic patients with high cardiovascular disease treated with GLP-1 receptor agonists resulted in lower cardiovascular events. So this has led to the new recommendations by the American Diabetes Association. This has already been mentioned that once the patient comes to you with diabetes and you have to choose a drug, whether the patient is on metformin or not, independent of his baseline HbA1c target, independent of his baseline HbA1c and individualized A1c target, if the patient has established atherosclerotic cardiovascular disease or indicators of high risk, this patient should be on a GLP-1 receptor agonist. If heart failure, on SGLT2 inhibitors, and vice versa. If patients have CKD with albuminuria or without albuminuria with reduced GFR of 60, these patients should also be started on SGLT2 inhibitor and GLP-1 receptor agonist. So to summarize all this, intensive glucose loading results in reduction in microvascular complications, reduction in CV events, and limited benefits also seen in mortality and macrovascular complications. Early intervention that we see in the UPPDS may be associated with greater vascular benefits after years, and these benefits may be greater in those individuals without a prior history of cardiovascular disease. Furthermore, it may take years of good glycemic control to translate into CV risk reduction. So the message would be to treat the patients aggressively from the start if they don't have established cardiovascular disease, so that this cardiovascular benefit gets translated over the years. Then when choosing the drugs, it's not only the efficacy of the drugs and to control the sugar values, like Dr. Osama said, prandial, postprandial fasting, or the HbA1c. This is the type of drug that has to be used to lower their cardiovascular risk. So much has been talked about hypertension. I'll not go into the details. The evidence of hypertension recommendation for diabetic patients comes from the trials which were done. These are the 4 trials called Advance, HOT, and Spring. If I just go quickly through these trials, in CORD trial, they looked at comparison of intensive treatment when they try to lower the systolic blood pressure less than 120 as compared to standard treatment of 130, 140. They found no benefit in the primary endpoint. However, there was a reduction in stroke risk of 41%. In advanced BP trial, they used a single combination pill, and the aim of they achieved the blood pressure of 136/73, which is slightly above the core blood pressure, compared with the blood pressure of 141/75 in the placebo group, and it showed reduction in microvascular events 9%, death from any cause 14%, and death from say CVD about 18%. The HOT trial included a small number of diabetic patients, and it also showed there was overall no cardiovascular benefit in most targets overall, but in diabetic patients there was a 51% significant risk reduction in CVD events. The SPRINT trial, the much talked about trial these days, was the one of the recent trials which showed that intensive treatment of systolic blood pressure less than 120 is resulted in reduction of primary composite endpoints 25% and reduced the risk of death by 27%. But in SPRINT trial, these diabetic patients were excluded. So how it translates to a diabetic patient is not clear. So the recommendation for treating diabetes and hypertension in diabetic patients is that these patients should be individualized. The blood pressure targets should be individualized through a shared decision-making process and to encompass all the cardiovascular risk, potential adverse effects, and patient preferences. So, as mentioned earlier, for individuals who have diabetes, hypertension, and high cardiovascular risk, those patients who have existing atherosclerotic cardiovascular disease or a 10-year atherosclerotic cardiovascular risk of more than 15%, a blood pressure target of less than 130/80 mg may be appropriate if it can be achieved safely. For individuals at low risk of cardiovascular disease, a treatment target of blood pressure of less than 140/90 seems to be appropriate. Lifestyle intervention should be advocated in all patients and style dietary pattern, which includes consumption of high fruits and vegetables, low-fat dairy products, and low sodium and high potassium intake will all result in slight reduction of hypertension as well. Drug therapy, as I mentioned earlier, ACE inhibitors or ARBs are the first one line to be suggested for treatment hypertension in diabetes and established coronary disease. These drugs are also the first line drugs for patients with albuminuria, and if you have to use a thiazide diuretics, long-acting agents should be used to reduce cardiovascular events such as chlorothalidone and dopamine. And when choosing the calcium channel blockers, hydropyridine calcium channel blockers should be used. Combination pills, when 2 or more drugs are used, they improve your compliance, patient's compliance, and provide better efficacy. So this is the algorithm by ADA. Without going into the detail, if blood pressure is between 140/90 and 160/100, start one agent. If patient has albuminuria, have to start ACE inhibitors or ARB. If no, we can choose any of these drugs. If blood pressure in the stage 2 hypertension, start with 2 agents. If albuminuria, one of the agents should be ACE inhibitors or ARB, and then as the blood pressure findings as well. Dyslipidemias has been talked in details. This slide, I just want to highlight a very important aspect of diabetic dyslipidemias. This is from MFA data and lower data, which shows at any given values of cholesterol, the cardiovascular death in diabetic patient is more than as compared to patients without diabetes. So if you see here, in a non-diabetic patient with a cholesterol value of more than 280, still the cardiovascular death is less than a patient of diabetes who has a cholesterol value of less than 180. So cholesterols are especially detrimental in diabetic patients. because they accelerate the atherosclerosis. The LDL particle is small, hence more atherogenic. So dyslipidemia management in diabetic patients, dietary management, reducing the saturated fats and trans fat. Glycemic control is also important to intensify the lifestyle therapy. Optimize glycemic control with elevated triglyceride levels of more than 150, and if they have low HDL levels. Exercise and weight reduction, and of course drug therapies. The statins as divided into two groups of high intensity statins and moderate intensity statins. High intensity statins will include atorva at a dose of 40 to 80, Suva at a dose of 20 to 40, and these agents and other at lower dose constitute the moderate intensity statin therapy. Now, statins reduce the cardiovascular disease events by 30-40%, and for every 1 millimole reduction in LDL, regardless of the baseline LDL cholesterol, the relative risk reduction for atherosclerotic cardiovascular disease is about 20%. And this has been demonstrated not only in diabetic patients but also non-diabetic patients. As you can see, all the events favor the treatment of statin. So, what are the guidelines about statin in diabetic patients? For patients that age 40 and 75 years age without atherosclerotic cardiovascular disease, patients should be on a moderate intensity statin therapy in addition to lifestyle modification. And we are talking about primary prevention here. For patients who are younger, age 20 to 39 years, with additional risk factors, it may be reasonable to initiate statin therapy in these patients as well. And in those patients who are high risk, especially those with multiple risk factors, aged more than 50, it is reasonable to start a high intensity statin therapy in these patients. Of course, for secondary prevention for patients all ages with diabetes and established cardiovascular disease, high intensity statin therapy should be added to lifestyle therapy. And for those patients who do not achieve an LDL target of less than 70 milligram per deciliter on maximally tolerated statin dose, consider to add other agents like ezetimibe and PCSK9 inhibitors in these patients. So just a tabular form of what we just discussed. How to approach triglycerides in diabetic patients? So triglycerides are basically a secondary target when treating dyslipidemia in diabetic patients. For patients who have fasting high triglycerides of more than 500 milligrams, should be evaluated for secondary causes of hypertriglyceridemia. And the medical therapy in this case is aiming to reduce the risk of pancreatitis. Now, in past, the grades have been used for treatment of triglyceride levels, but the studies have not shown that the combination of statin and fibrates show cardiovascular protection. Niacin and statins were also being used. Niacin to improve the HDL, but studies have failed to show any cardiovascular benefit from those as well, beyond the cardiovascular benefit that you get from the statins alone. So, in patients who have atherosclerotic cardiovascular disease or other risk factors on a maximally tolerated statin, and then LDL cholesterol is on target, and if we see the triglyceride levels are more than 135 to 499, the addition of icosapent to thiol can be considered to reduce the cardiovascular risk, which is the high dose omega-3, and the dose is 4 grams, up to 4 grams per day. So coming to the end, very important question that we get, we are asked in the clinics about platelet inhibition, aspirin therapy. So aspirin has an established role in reducing cardiovascular morbidity and mortality in high-risk patients. And this, we are talking about secondary prevention. So their role is established in secondary prevention. For primary prevention, data is controversial, both in individuals with and without diabetes. Our meta-analysis has shown that about 12% reduction in the risk of serious vascular events as primary prevention. And in this meta-analysis, men benefited more than the women. But at the same time, there were incidents and the risk of bleeding. So roughly, you get benefit and the risk of bleeding are almost similar when you are giving aspirin for primary prevention. So the recommendation is for secondary prevention strategy, aspirin low dose 75 to 160 2 milligram per day should be given in those patients with diabetes and history of supportive cardiovascular disease. For patients with supportive cardiovascular disease and documented aspirin allergy, clopidogrel should be used. And dual antiplatelet therapy is reasonable for a year after an acute virus syndrome. And now it's been recommended for further years because it shows benefit in reducing cardiovascular events. Now, aspirin as a primary prevention, the recommendation is to use low-dose aspirin in both men and women who are more than 50 years of age with diabetes and at least one additional major risk factors like family history of premature cardiovascular disease, who have hypertension, dyslipidemia, smoking, or chronic kidney disease or albuminuria. This is very important. This also increases their cardiovascular risk. These are the patients who can benefit from aspirin as a primary prevention strategy. But those patients who are not at increased risk of bleeding, and who are those patients who are increased risk of bleeding? They are the older patients, those patients who have history of peptic ulcer disease or who have history of GI loss. So these patients should not be given aspirin as primary prevention. Another practical point would be that if you are starting a long-term aspirin therapy in these patients, is maybe recommended to screen for respiratory infection and to make sure that there is no sporadic aspiratus. For other patients who are less than 50 years of age with no other risk factors, aspirin is generally not recommended for lowering the atherosclerotic cardiovascular disease risk. And in some individuals, you may engage them and explain to them the pros and cons of aspirin therapy in these patients. They might benefit from it. But in these patients, the risk of bleeding is actually overweighing the risk of infection.